There is no other implant that shows functional orientation of fibers. There's not one. This is the only one. This is so important that, you know, in my opinion, and I saw that Homely Wong in his lecture had his opinion at the bottom of his slides. My opinion is an implant should be like a tooth. And some of the things that we're doing with implants to make them kind of bizarre looking, I think that it's bizarre. So here, though, we see something that now we have an implant that's behaving like a tooth. I think that's a huge, important step in the right direction.
But at least in the meantime, this is decreasing the epithelial downgrowth. And Jack Ritchie, who's here in the audience, and I remember when Jack came up with this laser etching, you know, we worked on some of this thought process together, and Jack, you're a real good thinker, and he said, this looks like it could work, and sure enough it does. So, and you see that this is, you know, this is a couple of your cases, and you can see how beautiful this tissue is, and how this tissue, you don't even hardly see bone loss, you see bone over the top.
There's no question that from a scanning electron microscopic perspective, yes, in fact, we're getting a nice connective tissue attachment to these microchannels, and bone adapts to it quite nicely. So from a microtopographic perspective, there's some neat things going on. And bone to implant contact is extremely high.
When we look at where we place the implant in relation to the socket, I think Laser-Lok technology has also solved a big problem in the aesthetic zone. Because if you look at all other systems that have rough surfaces, those rough surfaces are present for bone maintenance. Whereas now we have Laser-Lok technology that has soft tissue advantages. In the aesthetic zone, where we have a scallop margin, we now have a little bit more flexibility, if you will, on where that implant is inserted.
So what do we know about Laser-Lok abutments? We know that a physical connection is identifiable at Laser-Lok versus machined abutments. Clinical probing pocket depths are reduced in a statistically significant manner. Tearing of the peri-implant mucosa occurred at 8-week biopsies. That's not true. What's true is we couldn't get the tissue for the biopsy off the abutments.
This is a publication that you've seen many times before, and this is the publication of Dr. Nevins that demonstrated that we can actually get integration of the soft tissue to an implant surface. So that soft tissue integration occurred, and the nice thing about this integration is that it leaves a zone of connective tissue that now is in contact with the implant surface, and it distalizes the most apical extent of the epithelial surface.
What you see in purple is the connective tissue attachment to this roughened surface. The collagen fibrils, as you'll see, circle these bumps in the titanium, and this will be a physical attachment. I will distinguish the difference between a Sharpie fiber in the cementum and a physical attachment. But both serve the same purpose. They prevent the apical migration of the epithelium, allowing the connective tissue attachment to be secure.